So yeah, I think people can hear me. So like I was saying, I'm saying hello, I'm from Kigali now, talking to you from Kigali. And I would like to thank everyone for attending this webinar. So we are thrilled to share the story of this launch of the largest trial of group pregnancy care ever conducted. So we will answer your question at the end, so feel free to post your questions. Next. So my name is Sabine Musange. I'm a lecturer at the University of Rwanda School of Public Health, and I'm the principal investigator of a cluster randomized controlled trial evaluating the effects of the group care in Rwanda. Next. So I hope this presentation can be helpful to anyone who is considering studying or implementing group antenatal care, especially in a low or middle income country. Today, I will cover the collaboration among Rwandan and US research teams, the Rwanda Biomedical Center and the Rwanda Ministry of Health, the creation of a context-specific model and monitoring and evaluation plan, the foundational work needed to plan for large-scale implementation and prepare the human resources needed for a successful rollout, and the design of the cluster randomized controlled trial to test the effects of group care in Rwanda. Next, please. But first, I would like to tell you about the Preterm initiative, of which this trial is part. The Preterm Birth Initiative East Africa is funded by the Bill and Melinda Gates Foundation to reduce the burden of prematurity in 3 countries, Rwanda, Uganda, and Kenya. Next, please. In Rwanda, the Preterm Birth Initiative partners with the Ministry of Health, the Rwanda Biomedical Center, which implements all Ministry of Health programs, and the University of Rwanda Health Institution. Next, please. So in Rwanda, we don't have perfect data to define the preterm birth rate. So we started with an estimate from the AV penny scale, which is about 10%. So we wanted to improve the quality of antenatal care, or ANC, and its uptake. So we decided to test a clinical intervention or a health systems delivery change specific to ANC that might decrease the preterm birth rate in Rwanda. Next, please. Then we asked ourselves, how can we redesign antenatal and postnatal care delivery to improve outcomes for women and newborns? Next, please. Okay, I think there is no slide, so let me just, I will speak closer to the laptop. So in Rwanda, all routine ANC is delivered at the primary health center, just like this one that you are seeing on the photo. And there is 466 of them in the country. Next, please. So after considering many possible interventions, we decided to test group antenatal care, or GNC, in our context. Just in case, if you are not familiar with GNC, it's an alternative way of providing all ANC services each pregnant mother needs, in which mothers are organized into groups that meet repeatedly over the course of pregnancy and sometimes after birth. Next, please. So each session includes the following components: a clinical assessment, the participatory learning activities, and peer support. Next, please. Why did we choose this intervention? We were interested in the work of Ikovic and all among young, low-income women in 2 large US cities who were at, excuse me, who were at higher than average risk. Sorry. So who were at higher than average risk for poor perinatal outcomes based on their basic demographics. In the individual RCT, women in group A and C experienced preterm birth 33% less often. Then we ask ourselves, could group A and C increase gestational age at birth in Rwanda? Next. So then, how does GNC work? So the current working hypothesis for how GNC might increase gestational age at birth is mothers who attend GNC visits experience increased social support. With increased social support, they experience less stress may result in increased cervical treatments, meaning the hormones that may be reduced when because the cascade of labor doesn't seven completed weeks and with a birth weight higher than 2,500 grams. A decrease in prematurity results in a decrease in neonatal mortality because complications of prematurity are the most common reasons for neonatal death. Next, please. Next, please. Okay. So we designed a cluster randomized controlled trial to test the effects of GNC at the facility level. Because gestational age at birth is our primary outcome, and we want to be able to detect at least 20% reduction in preterm birth, the sample size must be very large. So we have over 10,000 mother newborn diets. So we will also evaluate the effect of early urinary pregnancy testing by community health workers and obstetric ultrasound by nurses at these primary health centers. We are also planning to analyze many secondary outcomes, which I won't take time to explain here, but we are really interested in changes in ANC and PNC attendance, both the number of visits and ANC enrollment in the first trimester. Next, please. This project timeline shows the three phases of this very large trial. Phase 1 was the foundational work, and we have entered phase 2 by launching the trial and implementing group care. We expect to finish data collection by 2019, begin phase 3, and report our results mid-2019. So please stay tuned. Today I will share with you how we arrived at this point. That is, how we accomplished the formative work necessary to begin the largest trial of group care that has ever been conducted in the world. So next, please. So for our foundational work, we conducted a qualitative assessment and qualitative and facility assessment. So we conducted focus group among pregnant mothers, men, ANC and PNC, ANC antenatal care and postnatal care providers, and community health workers. We also conducted interviews with facility and district administrators to learn what they thought about ANC and PNC and the idea of group ANC or PNC. So we also conducted a facility assessment of 50 primary health centers and 6 district hospitals to assess availability and quality of care, learn which ones to be included in the trial, and how to match them as pairs for the CRCT. Next, please. So next, a technical working group of 10 Rwandan stakeholders was formed and joined by a group antenatal care technical expert from outside Rwanda. Their task was to define a uniquely Rwanda group care model. And I will describe the process in more detail later. Next, please. In order to implement group care at such a large scale, we knew we would need many GNC facilitators. So we first developed 6 Rwandan group care master trainers And they in turn trained 3 nurses and 12 community health workers at each of the 18 intervention facilities to become GNC facilitators. And this is for a total of 54 nurses and 216 community health workers. Each training session was 3 days long, and the master trainers trained all these new facilitators in about 1 month. Next, please. So you may be asking yourself, what was the process for accomplishing these important tasks? So in order to explain the answer, I want to tell you a bit more about some fundamental principles of group business. Next. Group ANC replaces a woman's traditional ANC visits. The conceptual model of group ANC is that 8 to 12 pregnant women and 2 co-facilitators form a circle. Next. In a literal sense, they sit in a circle. Every attempt is made to flatten hierarchies. All group members must feel equally valued, supported, heard, and trusted. In fact, the ideal group dynamic is one in which pregnant women speak more than the facilitators and all opinions are heard. Next, please. Everyone participates, even the shy ones. The group protects every member's confidential information. They share openly and they solve problems by consensus. In this way, all the women may have healthier pregnancy outcomes together than they would have achieved alone. This group process is enabled by the skills of the facilitators. Next. Before the first GNC visits could begin in Rwanda, we needed skilled facilitators because we implemented simultaneously in 18 health centers. 270 new facilitators were trained. These trainees were nurses or midwives and community health workers, and they experienced the same group dynamic during training. Even if the training session included a large number of people, they were divided into small groups of 8 to 12, sat in circles, and the master trainers acted as facilitators for the circle of providers learning to be facilitated. All the same principles of group care were applied to the training of the new facilitators. Next. We also developed 6 master trainers who train all the new facilitators and monitor their activities for model fidelity over time. These master trainers were developed using the same principles of group facilitation, and the facilitators of this learning circle were the UNC technical experts and the local stakeholder in this project, who really supports it nicely. Next, please. So to customize the GNC model for Rwanda, we convened another circle composed of stakeholders invested in maternal child health in Rwanda and interested in GNCs in group antenatal care potential. Our task was to define a group antenatal care model that will be sustainable in Rwanda's national healthcare delivery system. Again, using the same principles of facilitation fundamental to GNC, this circle, the technical working group, was facilitated by the GNC technical experts and myself. Next, please. So this is a technical working group composed of experts in many professions. There was an obstetrician, pediatrician, nurse, midwife, mental health specialist, and others. Next, please. We worked together to define the visit schedule, outline the curriculum, and plan for implementation. Next, please. So how did we get started? So first, we reviewed the key principles of GNC as described in the research literature. Then we defined the elements of care we definitely wanted to include, our priorities, and the limitations the Rwandan context will place on this model, our constraints. Next, please. The key principles of the GNC model have been described in research publications. These are the elements that other researchers suggest give the intervention its therapeutic effects. I will highlight 3 of these key principles, and you can read this full list later because we will send you the link to these slides. So the first one is the clinical assessment that ideally includes self-assessment, the participatory facilitated learning, and the peer support. Next. Next, please. Yeah. Our technical working group decided on the topics that must be included in the visit discussion guides, and you can find those topics here. We wanted also the group members to reunite for a 6-week postnatal visit, which is part of the Rwanda care package that is rarely attended. We wanted a GNC model that will be sustainable within the national healthcare system, as if it could be scaled to all of Rwanda in the future. Next. The unique constraints we define for our context where the total number of visits cannot be changed. No additional providers can be added to the workforce, and we chose sites for implementation that had 2 ANC providers working on any ANC day. Next, please. So now, to review the steps in our process. First, the technical working group came to all these decisions as a group in a circle of collaboration. Next, please. Then we developed master trainers. Next. And we engaged their creativity and commitment as trainers through the same group dynamic. Next. And these master trainers designed the curriculum they would use to train new GNC facilitators. Next slide. Next, the master trainers trained ANC nurses and community health workers together to be co-facilitators of GNC. Next. They were able to train large groups of providers by breaking out into small groups, each facilitated by a master trainer. The master trainers didn't rely on traditional teaching methods of instruction. They trained them in the same style as GNC, in participatory circles, just like the mothers experience. Next. Finally, and most importantly, the facilitators have begun providing GNC to the mothers, and the women are eager to enroll. Next. So if you are considering a GNC program for your context, you will need to plan for 3 other important considerations. First, you must develop an evaluation plan, and we recommend you measure the following. Key maternal and neonatal outcomes. For example, we will measure preterm birth, quality of care, that is tracking the content of ANC delivered, health service utilization, in this case, ANC and PNC attendance, uptake of healthy behaviors through a self-report survey, self-efficacy or health literacy, satisfaction with care, both for women and providers, impact of health on health system and service delivery, such as schedules, impact on other services and or flow of clients, cost and training needs. Next, please. You will need to decide supplies both for assessment and learning activities must be available at every facility that provides GNC. Here, you can see on the photo what we have decided each site must have. Next, please. The last consideration is scheduling. Scheduling is challenging. It takes quite a bit of patience to organize the women at each health center into groups matched by gestational age, but it's possible. Next. So I would like to end this presentation with this beautiful quote from Patel. I hope that I'm pronouncing that well. Patel and all that says, "We are happy to meet again. We are learning from each other, and we remind each other of many things. We belong." Next. So here's a list of references which you can return to later when we will send a recording of this webinar to you next week. Next slide. So thank you for your attention, and we have 15 minutes for questions. If you have a question, you can post it in the chat window. Next, please. But before moving to Q&A, I would like to acknowledge the work of all my collaborators, without whom this work would not have been possible. Thank you again for listening, and now you can ask your questions. So yeah, so I'm looking at the questions. I have so many questions. So yeah, there is a question on strategies that we use to reduce hierarchies between ANC providers and the mothers. So actually what we did, we tried to improve the facilitation skills of the nurses so that they listen to women more than they talk. So they have to leave the floor to the pregnant women to talk and bring their problems or their own, share their experience, and they will just talk a little bit just to if there is something that is a discussion that is not in the right direction, and try to redirect it on the right path. But this was something that we worked on by improving facilitation skills and telling them to observe and support. So what we are also doing to make sure that nurses are doing that, the providers, is that we have our master trainers that are going to make visits to these facilities. They have a mentorship plan already developed, and they are making their visits during the first week. They will do another visit during the week 5, week 9, and etc. So they have a mentorship plan that they will follow, and that will help us to make sure that nurses, providers in general, are following what they have been taught. So let me see. Okay. Now the next question is, how did you make mothers' participation autonomy? How did you measure it? Yes, that's the question. So after each visit, the providers sit together and they complete a debrief form, just to go through the session and see what went well, what went wrong, how to improve that. So with this process, we ask the question if the mothers were speaking, if they were able to speak. And looking at that, okay, because we started last month, we are going through the different debrief form, and we are able to see where we have some issues and make sure that we have a feedback for these providers. The other question is, what specific types of training are you implementing? what did you find most lacking in knowledge of the matters in regards to pre and postnatal care? So the training that we implemented are the training we trained nurses and midwives and community health workers in group care. So we also conducted other trainings related to urinary pregnancy testing and ultrasound. And what did you find most lacking knowledge of the matter? So some, for some matters, we did a qualitative before starting the trial. Some of the matters, for example, some of them didn't know about especially for the postnatal care, because it's not really attended. Some of them didn't know about that, and maybe that was why they were not attending those sessions, services. But for antenatal care in Rwanda, we have this cultural belief where if you say too early that you are pregnant, then people can do something about your pregnancy. So this is the first barrier that we need to work on. But also some women don't understand why they should come 3 to 4 times. They feel like coming once is enough. That's why they come always. Most of them come late towards the end of the pregnancy, and they don't feel that it's a problem. So I think we need also to work a lot on sensitizing women that if you come early, we are able to follow up with you, to follow your pregnancy and detect any complications as early as possible. Do you have any okay, the next question is, do you have any political issues that affect your work output? I don't really understand what you mean by work output.
Maybe strikes or those kinds of things.
Oh, no, okay. If this is what you are referring to, maybe the strikes or something like that, we don't have. So, okay, we don't have up to now, because I don't know what will happen in the future, but we don't have. So I'm very worried about stakeholder fatigue. What were factors that influence recruiting and efficiency of stakeholders with respect? Okay, so for the stakeholders that we involved in the technical working group, so these stakeholders are already part of the maternal and child health technical working group at the Ministry of Health. And what we did is that we first introduced the study in that during one of the meetings of the maternal and child technical working group, telling them what we were planning to do. And with the Ministry of Health and stakeholders themselves, so we listed the stakeholders that should be in part of the technical working group. So most of them were really interested, and they were available to meet when we had our PTBi technical working group. Actually, we had maximum 4 meetings, but full-day meetings, where we worked on developing the model. So we didn't experience any fatigue from them. So rather, they were really interested and they participated until the end. And we didn't have any problem about that. So how long was the training for the champion training? Then how long was the training for the master trainers compared to the nurses and providers? So
The master trainers.
yeah. So the training of the champion is myself. So I was already involved from the beginning. So I didn't need training as such, because I could understand the context and the issues that we are facing here in Rwanda. And then the training of the master trainers was a 3 days training, which was exactly the same as the nurses and the providers for the GNC model. Yeah. Yeah, and then of course they are having ongoing contacts with the GNC consultant. So what is the biggest challenge you face in implementing scaling? So we are not scaling yet, but implementing, yes, we have some issues, especially with scheduling. Scheduling up to now, okay, now it's getting better, but depending on the attendance, because we have this issue of women coming late for ANC and not coming early enough. So, and our criteria, eligibility criteria, is that we enroll women that are 24 weeks, that are less than 24, who are less than 24 weeks pregnant, and we don't have many women. Okay, at the beginning we did it, so that was a challenge to be able to have groups at the pace that we thought that would be possible. So what we did then, because we have a really good community health network in Rwanda, so in each of these facilities, we convened a meeting with the community health workers, giving them the message that they should bring to the villages and ask women to attend the facility early enough so that they can be enrolled. And we are seeing now the effects of that because we are getting more and more women, and we are able to have groups on a weekly basis. Because at the beginning we had groups, for example, after 2 weeks. And now in some of these facilities, we are able to have group visits every week. Hi, my question for the presenter is this: from my experience, growth restricted term babies. Okay, I have another question. From my experience, growth restricted term babies are often misidentified as preterm. How will the study determine whether there was a true reduction in preterm birth and not just an increase in birth weight? So that's really a big issue also here in Rwanda, and that's why in some of these facilities we are introducing early ultrasound for gestational age assessments, and this will be in 18 facilities. But also, something that we didn't present here is that we have also a data strengthening component, because we realized when we did our facility assessment that we had some issue of data quality, and that's why we developed a data strengthening training to make sure that all these facilities are measuring gestational age the right way and are identifying preterm the same way. So the next question is it's common that in low and middle income countries, private provider participation form a huge bulk of healthcare provision and factors into high out-of-pocket payments on the part of users. So how does this factor into achieving your goals? So in Rwanda, especially in rural area, let's say first in Rwanda overall, the private sector is quite small, and it's mainly concentrated in the big cities, and mainly the capital city, actually, Kigali. So in rural area where we have most of these health facilities, there's no private providers. And the primary health centers is the main health facility there to provide all healthcare services. So about high out-of-pocket payments, in Rwanda, we have also this community-based health insurance, for which the coverage, if I'm not wrong, is around 70% currently. So many of these household of, let's say, pregnant mothers will have the the health insurance will be covered by this health insurance. But of course, we will always have cases where they don't have health insurance and somehow will be affected by this. But for preventive services, in Rwanda, the cost is not that high. It's around 200 Rwandan francs, which is maybe because $1 is around 800 something. So it's few cents, but of course this can still be a lot of money for some of these households. So we are not giving anything for free because we don't want to make changes in the system that we won't be able to scale up at the end of the study. So during the group care, during these visits, women are always reminded to make sure that they have a health insurance before before the delivery. So this is a message that is consistently given to these women during the different visits. The next question, it's, are children welcome in the groups? So yeah, this is, we have left this question up to the group to decide, because during the qualitative also, we asked people if they wanted the mother-in-law to be there, the husband, etc. And some of them really wanted these people to be in the group with them. So we decided that we are not going to put that in our model design, but we will leave it to each group to decide. So during the first meeting, they discuss about all that, and they decide if yes or no they want the children or the husband or the mother-in-law to be present during the group meeting. So let me see if I have any other questions. Can I clarify a point you made in the beginning? The graph you showed was it showing the number of preterm births with and without GNC? Yes. This comes from the ICOVIX trial, and I think you will see that in the reference slides you'll see the paper that we have at the end of the presentation. So yeah, so I will just I don't have any other question. So if there is no other question, I think we can end up the presentation now. And we will send you the link to the video next week. Thank you all for attending, and have a good day or good evening, depending on where you are. Thank you.